Hello everyone. Now we are going to discuss about descriptive epidemiology. I am Dr. Anusha, Assistant Professor in the Department of Community Medicine. And we are going to discuss the descriptive epidemiology topic under the following headings like classification of epidemiological studies, introduction, and procedure in descriptive studies like defining the population to be studied, defining the disease under study, describing the disease by time, place, person, distribution, and measurement of the diseases, comparing with known indices, and finally formulation of an etiological hypothesis. And we will discuss about uses of descriptive epidemiology also. Before going into the topic, we will see classification of epidemiological studies. So epidemiological methods are divided into two broad categories: observational studies and experimental or interventional studies. Observational studies means we will only observe, we will not do any intervention, we will not follow any preventive method or anything we will not do. We will just observe. And second category is experimental or interventional studies. In this, we will give particular type of intervention like new drug or cessation of smoking, like that, whatever it is, we will intervene. So that is second thing. And again, observational studies are classified into two categories. One is descriptive studies, which we are going to discuss now, and second one is analytical studies. So descriptive studies means it will only describe the disease in detail like time, place, person, distribution. But analytical studies will see association also, like association means strength of association, relative risk. So we will do 2 into 2 tables and we will see the association, and with help of that we will tell about risk factors for that particular disease. And analytical studies are ecological studies, cross-sectional, case control, and cohort studies. And the second category, experimental or interventional studies, are of randomized control trials, field trials, community trials, and non-randomized control trials also. Whatever is the epidemiological study design, first we should write the definition of epidemiology, which is study of occurrence and distribution of health related states or events and processes in specified populations, including the study of determinants influencing such processes and the application of this knowledge to control of relevant health problems. So in this, some keywords you should remember. So epidemiology is study of occurrence and distribution. So occurrence means how it is occurring, and distribution in terms of time, place, person, distribution, and not only occurrence and distribution but also determinants of such health problems. And all this knowledge we will use for controlling of health problems. So application of the same knowledge to control the relevant health problems. So these key terms you should remember: occurrence and distribution of health related states, and also determinants and application of the knowledge to control the same. So this you should remember as definition. And coming to the introduction of descriptive epidemiology, means these descriptive studies are first phase of investigation. So for any disease investigation, like if unknown disease is also occurring, means first we will start with descriptive study designs. So in this descriptive study designs, we will allow nature to take its course, and we will not intervene anywhere. That means we are not modifying, we are not intervening in the middle. We are just allowing the nature to take its own course. And we are going to describe the disease under time, place, person, distribution. Time means when the disease happened, that is time distribution, and where the particular problem happened, that is place distribution, and who are the affected persons, so that is person distribution. So mainly descriptive studies will describe the disease in time, place, person, distribution. Now we will see the procedure or steps in descriptive study design. So the following are the steps of descriptive epidemiology. First is defining the population to be studied, and second is defining the disease under study, and third is describing the disease by time, place, person, distribution, and fourth one is measurement of disease, fifth one is comparing with known indices, sixth is formulation of an etiological hypothesis. And each and every step we are going to discuss in detail. The first step is defining the population to be studied. So descriptive studies are investigations of populations, not individuals. So its main concern is about the population under study, not like individual person. Suppose an unknown disease has happened in community A. So we should define the population under study, like in that community A, what is the total population number and their age distribution, gender distribution, their occupation, their cultural characters, and not only that, we can take all population in community A, or if the population is large, we can take only representative sample with help of sampling techniques. Either we can take whole population or we can take representative sample, or we can take specifically selected group like particular age only, particular sex only, or only hospital patients, only school children, depending upon the disease under study. And not only that, this defined population should be large enough for specific rates to be meaningful. Say for example, only 4 persons are there, 5 persons are there, then there is no meaning for the incidence and prevalence rates. So the defined population should be large enough. And this defined population should be stable without migration in and out, and it should not be distinctly different from the other regional communities, and community participation is a must. That means without their cooperation and participation, we as a investigators cannot achieve much. So community participation is must. So this is defining the population to be studied. That means about that population under study, we should collect all the details. And second step is defining the disease under study. And the disease must be defined so that we can measure with accuracy. And invalid definitions are a powerful source of errors. That means uh, in the previous example itself, community A. So in that community A population, defined populations, we should segregate them into diseased category and non-diseased category. If we have to segregate into diseased category, means we should have proper definition for disease under study. So for that, defining the disease under study is very important. If we are not giving appropriate definition for the disease, some diseased populations can go into non-diseased category, and some non-diseased persons will come into diseased category if we are not giving proper definition for diseased. Here we will take some example of tonsillitis. So for tonsillitis, to treat this tonsillitis, clinician can give definitions like inflammation of tonsils caused by infection, usually with Staphylococcus pyogenes. So they can tell like, so it might be due to Streptococcus pyogenes, only inflammation like that. Visually they can see and diagnose, and with help of that they can treat. But this definition is not appropriate for categorization into diseased and non-diseased. So instead of this clinician definition, we should form separate definition, which is epidemiologist or operational definition. So this operational definition for tonsillitis will be like presence of enlarged red tonsils with white exudate, which is on the throat swab culture grows predominantly Streptococcus pyogenes. So with help of each and every detail, we can categorize the person as diseased or non-diseased. So if this enlarged red tonsils with white exudate and on throat culture Streptococcus pyogenes is present, if the person follows all these criteria, then only we will categorize them into diseased person. So this is defining the disease under study with help of epidemiologist or operational definition. We have defined the population under study, and we have defined the disease under study, and now we will describe the disease in detail in terms of time, place, person, distribution. This is very important step. So time distribution means the particular disease which we are studying about is common in which year or in which season, like it is seen commonly in summer, winter, or rainy season, or which month it is more, or which week in the month it is more common, or which day. weekends, weekdays, like that. Which hours of the onset? That means it is more common in early morning or in the evening times, like that. And which duration it is common, like that. We will see in time distribution. Again, we will discuss about time distribution in detail. And place distribution means in which climatic zones this disease under study is common, and which country is affected more, and which region is affected more, and whether there is any urban and rural differences. That means it is more common in urban areas or rural areas, and which local community is affected, which towns it is affected, whether it is affected more cities or institutions. So like that we will describe the disease by place distribution. And third one is person distribution. Person distribution means the deceased persons. So age distribution, so in which age it is common, whether it is the particular disease is common in childhood or adolescent or adulthood or old age, and which gender it is affecting more, like males are more affected, females are more affected, and marital status, like whether married people are more affected, unmarried people are more affected, and which occupation group is more affected, which socio-economic status group is more affected, like whether low socio-economic status is more affected or higher socio-economical classes are more affected, and whether uneducated people are affected more or when educated people are affected more, and which birth order it is affecting more, like firstborn children or more birth order like third, fourth, like that. And family size means small family sizes are more affected or large family sizes are more affected, and which height group persons are affected, which weight group persons are more affected. And so among the person distribution, what is the blood pressure levels, blood cholesterol levels, personal habits, whether they are addicted to smoking and alcohol. So depending upon the disease under study, we will take each and every detail about time and place and person distribution. We will discuss time distribution in detail. Again, in this time distribution, there are three types, like short term fluctuations, periodic fluctuations, and long term or secular trends. Short term fluctuations means which will be seen in short duration, like days, weeks. Periodic fluctuations means which will be like seasonal or cyclical. Seasonal means in which seasons it is more, cyclical means once in 3 years, 4 years, 2 years, like that, yearly. That is periodical trends. And long term secular trends means it will be seen over decades. So based on the duration, they are categorized into short term fluctuations, periodical fluctuations, and long term or secular trends. And now we will discuss about short term fluctuations here. So short term fluctuations means sudden outbreak of cases will be there. So this is epidemic. So an epidemic definition is occurrence of illness or disease clearly in excess of normal expectancy. So here we will think that clearly in excess means it will be in high numbers, like that we will think. But say for example, in a community there are no rabies cases till now, but suddenly one or two cases are occurring, means that is also outbreak only, because previously there are no cases and now one case happened. So even though it is a one case, but it is clearly in excess of normal expectancy, so that is also uh, outbreak. And there is a limit, like up to plus 2 standard deviation is okay, variation is okay, but more than 2 standard deviation variation, like high cases are happening, means that is also a outbreak. And this outbreak or epidemic curves will be different in different types. Again, in short term fluctuations there are three types: common source single or point exposure, common source continuous or repeated exposure, propagated person to person or vector. And about first one we will discuss, which is common source or single or point exposure. That means to a common source people are getting exposed. That too only once they are getting exposed. Say for example, because of contaminated environment or infectious agent. Say for example, in MBBS hostel mess, in the afternoon meals the food is contaminated. After that, till evening or night, the students identified symptoms like acute gastroenteritis, like lower abdominal pain, then loose motions, vomitings, So like that they have symptoms. So from that common mess they have eaten. So that is common source, and that too in the afternoon they have eaten from that mess. So that is single or point exposure. So after they identified all these acute gastrointestinal symptoms, so they will close the mess for some period until the investigation goes on. So only once they have been exposed, and from common source they have exposed. So that is example for food poisoning. And other example for this is Bhopal gas tragedy. So in Union Carbide pesticide plant, so because of that blast, methyl isocyanate got released, and many people got exposed to that, and even about 4,000 people died. So that is also common source and single or point exposure. And even Minamata disease, so this means to methyl mercury. So the people who have eaten the fish contaminated with methyl mercury, people got affected. That is Minamata disease. So this is example common, so example for common source. That means from common point they are getting exposed, and only once they are getting exposed. So for that reason, all the cases, almost all the cases will be developed within single incubation period. So you can see the graph. So first it is flat, so that is incubation period, and then the graph will rise the peak suddenly, sharply, and it will rise suddenly and it will fall suddenly because the exposure has been stopped, and there is decrease in the cases also sharp. So rise will be sharp and fall will be sharp. So this is common source single or point exposure curve. And second thing we will discuss about common source continuous or repeated exposure. So same like first one is common source. So from common source they are getting affected, but they are not exposed to a single time, but instead they are getting exposed continuously or repeatedly. So that is nothing but prolonged exposure. So the epidemic continues over more than one incubation period because they are getting affected in different times, and they are having different incubation periods, more than one incubation period. So here the best example of a well of contaminated water. Say for example, in a village common well is there from where they are getting water and drinking, and that well is contaminated. So from that well the whole village is consuming water, and all the persons will not come at the same time and carry water. So some people will come in the morning, afternoon, night, or the next day. So depending upon the time of exposure, the incubation period will vary. But continuously they are, or repeatedly they are getting exposed to that common source. So this is common source epidemic, continuous or repeated exposure. So not only this example, nationally distributed polio vaccine. Say for example, a batch of polio vaccine, polio virus vaccine is contaminated. So because of that, so the children who are receiving that particular batch polio vaccine are getting adverse, commonly adverse events following immunization, vaccine associated paralytic polio, like that they are getting. But at the single time, the vaccine will not be given all over the India. So some people in some areas today they are conducting vaccination sessions in some places after 1 week, or after 10 days, like that they are conducting immunization sessions. So based on that the incubation period will vary. And other example is waterborne cholera. And here if you see the graph, so after incubation period the graph will rise suddenly, sharply, but it will continue as plateau because so after different incubation period again the we will be getting different cases. So for that it will continue high and it will fall gradually, not suddenly like point exposure. And third is propagated or person to person or vector type. So here transmission continues until susceptibles depletes or herd immunity lowers. So this means you can remember the example of Stalin movie. So one person, some three persons are getting infection and disease, and from those three person again 10 persons are getting disease, like that it will continue. Until when it will continue means until the susceptibles are depleting, until most of the populations are being immune. So till that time this outbreak will continue. And the famous example we know is COVID-19. So it continued as a public health problem until, so most of the susceptibles are depleted. That means after majority of the population is immune to that particular COVID-19 disease, it continued as an epidemic, and it continued as pandemic. So after majority of the population became immune, it decreased. So this is propagated person. So it can transmit from person to person through direct contact, or through droplets, or through vector borne. Examples are COVID-19, hepatitis A, and polio. So here the graph, you can see, like gradually it increase, not like suddenly. Like first two examples, it will rise gradually, because from 1% some 3%, and from 3% from 9%, and from those 9% into 3, like that it will rise gradually, and it will also fall gradually. So these three curves you should remember, and you should be able to identify. In the first thing, it is rising sharply and falling sharply, and second example, it is rising fastly, but it is continuing as a plateau, and then it is gradually falling. But in the third example, it is rising gradually and falling gradually. This is about short-term fluctuations. And in time distribution, we will see other types like periodic fluctuations and long-term or secular trends. First is periodic fluctuations. Periodic fluctuations means there are seasonal trends or cyclical trends. Seasonal trends means some particular diseases are common in particular seasons. Why it is different in different seasons means it will be driven by environmental conditions. So that particular environmental condition is favoring the multiplication of particular vectors, and the humidity is favoring particular organisms, and temperature is favoring, like that, because of those environmental conditions. So particular disease will be common in particular seasons. So examples like measles, upper respiratory tract infections will rise in winter, and vector borne diseases like malaria, dengue will rise in rainy season, as you know. So not only communicable diseases, but non-communicable diseases also will show this seasonal trends. Like sunstroke will be seen due to high temperatures, which will be seen during summer. And second is cyclic trends. Cyclic trends means this outbreaks or epidemics will be happening in cycles, like once in 5 years, once in 10 years, like that. In cycles, these outbreaks will be happening. So why means it is due to variations in herd immunity. Herd immunity means, so once the outbreak happened, so to that particular antigen we are immune. So as most of the people are immune, this epidemic will not continue. And after some time, so our immunity will be lower. So after that, or the agent itself will mutate and show different antigenic characteristics. So we are immune for the old antigen, but we are not immune for the new antigen. So because of that, again, most of the people will be susceptible, and the outbreak or epidemic will happen. So examples are influenza pandemics will be happening in 7 to 10 years due to antigenic variation. So once the influenza pandemic comes, so most of the people will be immune, and after 7 to 10 years, this influenza virus will change its antigenic characteristics, and to this new antigen we are not immune. So again this outbreak will happen. So most of the people will be susceptible. So again the outbreak will happen. And not only communicable diseases, even non-communicable diseases will also show cyclic trends. Examples are US automobile accidents peak on weekends. So weekends means holidays. So most of the people will go outside, and traffic will be more, and because of that, accidents could peak during weekends. So this is cyclic trends. So cyclic and seasonal trends will be examples for periodic fluctuations. And now we will see about long-term or secular trends. As the name suggests, it will show long-term, very long-term fluctuations. It can be decades also. So as we told, the secular trends will show variation, like several years or decades, 10 years, 20 years, 50 years, like that. And these particular diseases either will show upward trend or downward trend over the years. And we are seeing that now non-communicable diseases are showing upward trend, like coronary heart diseases, diabetes, lung cancer, hypertension, like that. And communicable diseases are showing downward trend, like tuberculosis, polio, like that. Those communicable diseases are showing downward trend over the decades, and non-communicable diseases are showing upward trend. Time distribution is over, and now we will see place distribution. Place distribution means it can be of international, national, rural, urban and local distributions. International means so particular diseases are common in particular countries compared to other countries. Say for example, stomach cancer is high in Japan and low in US. So the reasons could be different, like lifestyle factors, genetic susceptibility and eating habits, like that. And oral and cervical cancers are high in India, so this could be due to high tobacco chewing habits, gutka, pan, like that. And cervical cancer means so because of high prevalence of sexually transmitted infections, cancers are high. So like that, in particular countries, particular disease burden will be different. And second one is national. So national means even though within the same country, different places and different states will show a disease burden differently. Examples like in India, so endemic goiter will be more in Himalayan goiter belt, as we all know, because in the environment iodine content will be less. And fluorosis, so fluorosis also will be common in particular places, example Nalgonda. And malaria also, there will be variations within India. And rural urban variations, like particular diseases will be common in rural areas and particular diseases will be common in urban areas. Like in urban areas, chronic bronchitis, cardiovascular diseases, accidents will be more because of more traffic, more sedentary lifestyles, eating habits, lifestyle, like that. And in other hands, rural areas, increase of skin diseases, zoonotic diseases, soil transmitted ailments will be more because they are more into contact with environment and soil and animals. And other is local distributions, that means within the same place also the disease burden will be different. Say for example, in Warangal also, the cases will be clustering only in particular areas, not in other areas. So how can we depict it? Means so see the image. Each case, if we are we should take first image of Warangal, so spot map of Warangal. So in that, each case will be denoted by a dot. So where this particular disease is happening, we should denote it with dots. After that, we should see where the clustering of dots is there. Clustering of dots means clustering of the cases. So if we see any clustering of the case in particular place, we should investigate deep, because more clustering is there means so there should be some cause in that particular area for the clustering. So it could be like water sources, it could be anything, but clustering is there means the cause should be around that particular region. So famous example means cholera spot maps was prepared by John Snow. And in so this is about place distribution. And the classic example of place distribution is migration studies. Migration studies means distinguishes genetic versus environmental factors. That means whether it is the effect of environmental factors or genetic factors we can identify. So example means men of Japanese origin living in USA have higher rates of coronary heart disease than Japanese men living in Japan. That means both are of same origin, Japan only. One person is living in USA and one person is living in Japan. But the environmental factors, lifestyle, eating factors are different in USA and Japan. So these Japan persons who are living in USA have higher rates of coronary heart disease. Why? Means this is not due to genetic effect, because these two persons are having same genetic origin. But this is due to environmental effects. So, this higher rates of coronary heart disease is due to environmental factors rather than genetic effect. Time distribution is over, place distribution is over, and now we will see person distribution. So person distribution means host characteristics, and first one is age. So we all know that different diseases are common in different ages. Like in childhood, diarrheas are more common, acute respiratory infections, malnutritions like protein energy malnutritions are more common. and in geriatric people, skeletal problems, mental problems, social problems, so they are more common in old age. So that is age distribution. So in that age distribution also, some diseases, few diseases will show peaks in different ages. So see the image which is on the right side. So on x-axis age is being shown, and y-axis rate of incidence is being shown. So in some diseases like Hodgkin lymphoma and breast cancer, so there will be two different peaks. That means this Hodgkin lymphoma is peaking in the age between 20 to 30 years. That means we are seeing more cases in 20 to 30 years, and not only then, but we are seeing high incidence in 70 to 80 years. There are two different peaks. So that is bimodal distribution. So because of the disease, the clinical features, signs and symptoms will be similar. Even though they are similar, there could be two different sets of risk factors or causative factors. And second one is person distribution is sex. We all know that males are more prone to some diseases and females are more prone to different diseases, and this could be due to biological or genetic factors or cultural factors or cultural variation. So the classic example is 4:1 male to female ratio in lung cancer due to smoking. So as we are seeing more smoking in males, we are seeing lung cancer proportion also more in males. So that is due to cultural variation. And biological variation means we are seeing that risk of diabetes is more among females compared to males. And third one is marital status. So marital status means some diseases are common in married people and some diseases are common in unmarried. So lower mortality for married people. So this can be due to healthy people will tend to get married. So among them disease burden is less, and unhealthy unmarried people can show disease burden high. And other factor in person distribution is social classes. We all know that upper classes are prone for particular diseases like lifestyle diseases, diabetes, coronary heart disease, and lower classes are prone to poorer life expectancy, even communicable diseases like that. And ethnicity. So ethnicity means because of genetic or environmental differences. So tuberculosis, sickle cell anemia, because of genetic predisposition, some persons are more risk. Say for example, sickle cell anemia is common in particular tribes or particular ethnic groups. That is because of genetic mutations which will be carried through generations. And other thing is occupation. So we all know that different occupations will have different risk. So as doctors, we are more prone for communicable diseases because of treating patients, and because of sedentary lifestyle, and because of lifestyle factors also we are prone for lifestyle diseases also. And silicosis is more common among coal miners, and heart diseases in sedentary jobs. And other example is behavioral factors like smoking, drinking, overeating, sedentary lifestyle. So these are the factors responsible for person distribution. So till now third step is over, which is describing the disease in terms of time, place, person distribution. And now we will see step 4. Step 4 is measurement of the disease. And in measurement of the disease, cross-sectional studies will be there, longitudinal studies will be there. If we are doing cross-sectional studies, we will get prevalence, and if we are doing longitudinal studies, we will see incidence. So cross-sectional study means snapshot of the population under study. So in the starting example, we said that unknown disease outbreak is happened in community A. So there we will go only once and we will collect the data, and it is simplest observational study, single examination at one point of time. So with help of that prevalence of that particular unknown disease, we will know. Prevalence means so total how many cases are there by population at risk into 1000. And this cross-sectional studies are best for chronic diseases compared to acute diseases, because acute diseases means when we are seeing them, they are diseased, and because it is acute disease, after 1 month the disease will be cured. So it is more useful for chronic diseases like hypertension. And in this cross-sectional studies, at that snapshot, we can collect details like their age distribution, sex, physical exercise, body weight, salt intake. So many details we can collect based on the disease we are studying. And if we are conducting longitudinal study means follow-up. So cross-sectional studies are only snapshot or photo shoot. Longitudinal studies are like video shoot. That means continuously we are monitoring and we are doing follow-ups. So this is repeated observations in the same population over a prolonged period in the form of follow-ups. So because we are going multiple times, say for example, in the first visit only 4 people got the disease, and in the second visit newly some 3 persons got the disease. So that new cases also we will know. So we can calculate incidence rate. And it is best for because we are following up them for a particular type of particular period of time. It is best for studying natural history of disease, future outcomes, and identifying risk factors. Even though these longitudinal studies are highly useful, but it is time consuming. So, and again, cross-sectional studies are of two types. Descriptive cross-sectional studies will be there, analytical cross-sectional studies will be there. So, descriptive type of cross-sectional studies means mm, uh, we will only describe the disease. We will collect the data and we will just describe in time, place, person, distribution and all. But analytical type of cross-sectional studies means we will see association also. That means 2 into 2 tables we will form and association we will see. And now we will see step 5 and step 6. Step 5 is comparing with known indices and step 6 is a formulation of hypothesis. So step 5 is comparing with known indices. That means comparing the collected data with known indices, which will identify the group set, increase the risk, and it will yield the etiological hypothesis. So this can be best said with the example of lung cancer. So comparing with known indices means, so till the data we have collected, we have come to conclusion after comparison that only males are getting lung cancer, and that too only smokers are getting lung cancer. Why it is happening? So with that we will come to a hypothesis that the smoking could be the a causative factor for lung cancer. Like that we will form a etiological hypothesis. So that is comparing with known indices. That means with the data we have collected, we will compare with what age it is common, with what gender it is common, with what lifestyle it is common, with what occupation group it is common. Like that we will compare with known indices. And the sixth step is hypothesis formulation. And we should not say in the same example that cigarette smoking causes lung cancer. Like that simply we cannot say. So we should explain in detail, like with population characteristics, with specific cause characteristics, plus what is the expected outcome because of that particular habit, plus whether there is any dose response relationship and whether there is any time response relationship. So completely we should tell. So then it will give complete hypothesis. So here we will see with example incomplete hypothesis will be cigarette smoking causes lung cancer. So this is very incomplete because it is not telling that how many cigarettes they are smoking and for how much time they are smoking, and like that it is not complete. And among smokers how many people are getting lung cancer, that is also it is not telling. So that's why it is incomplete. And complete hypothesis will look like the smoking of number it is mentioning, so 30 to 40 cigarettes per day, so that is dose response, causes lung cancer. So lung cancer is outcome in 10% of the smokers. So that is smokers are the population. So among all we are not getting, but among the 10% of the smokers. And after how much exposure time means after 20 years of exposure. So like that completely we should tell the hypothesis. So till now we have seen all the 6 steps of descriptive study designs. So now we will see what are the uses of descriptive epidemiology. First use is it will tell the disease magnitude. So with as we discussed, with help of cross-sectional studies we are getting prevalence, and with help of longitudinal studies we are getting incidence. So that is morbidity of disease. And along with that morbidity rates we will also get mortality rates. Mortality rates means how many people are dying. So even case fatality rate we will know. And proportional mortality rate, specific mortality rate, so all that mortality rates also we will know. So that is disease magnitude. And second one is it will help in forming the etiological hypothesis. So in the final step we have formed the etiological hypothesis. So after seeing in detail what is the pattern of the disease, so it will form a etiological hypothesis about the disease and about the cause, and this etiological hypothesis will be tested using next type of study designs like cohort studies, case control studies, randomized control trials. It will be tested and it will be confirmed. And third use is public health planning. Say for example, if we are identify that that particular outbreak is due to contamination of milk, say for example, so it will help in on that point only that milk supply will be cut down, and next measures will be taken for proper pasteurization and utilization of only pasteurized milk, like that. So next planning will be done to decrease the next emergence of disease, that particular disease. And fourth is research contribution. So as we have said that it is just a formulation of etiological hypothesis, and next the testing will be done and confirmation will be done. So testing will be done with help of analytical studies like cohort studies, case control studies, and confirmation will be done with experimental type of studies like randomized control trials. This is for today about descriptive epidemiology, and I'm Dr. Anusha, and subscribe to Community Medicine Made Simple by Dr. Anusha channel. Like, share, subscribe, and comment down if you need any specific topic for explanation. Thank you.